Thank you. Good afternoon, and thank you for staying this late in this awesome SAGES meeting. I would like to thank SAGES for the privilege of the podium to be able to present our work. The title of the session is Do Normal Gallbladder Ultrasound Rule Out Acute Cholecystitis? For this to wait 7 seconds, just hands up who did an outpatient cholecystectomy that turned out to be very inflamed, needed a drain, or converted to open. So that was the trigger for this talk. Okay, no, sorry, thanks. So this study was designed really to assess the reliability of ultrasound in acute cholecystitis. And the question was how to do that. The final thing we established on is really to compare the ultrasound report to the pathology specimen of the gallbladder, whether it showed acute cholecystitis or no, because we found so many discrepancies when we looked at the post-op diagnosis in the upright report. As it's thought to be the gold standard to diagnose acute cholecystitis. So the methods was a retrospective review. We looked at 1,000 patients. Included all the cholecystectomy was done between 2016 and 2018 in a single institution. And we included almost everybody who had cholecystectomy, and the ages we found was 10 to 93. And the inclusion was any patient who had a gallbladder ultrasound within 10 days of surgery that showed the presence of gallstones or sludge were included. It's most commonly that the patient will come to the ER, they do ultrasound, looked okay, just cholelithiasis, send them to clinic or to be done in the following 10 to 14 days. So we kind of figured out maybe 10 days would be close to what we need to do. And then the ultrasound report, we just looked at the one that has gallstones, and anything else additional we included as positive for signs of acute cholecystitis. The gallbladder was thicker greater than 4 millimeter, pericholecystic fluid, sonographic Murphy sign, and we used a binomial logistic regression model to assess and predict for the likelihood of the participants having a positive pathological results depending on their ultrasound result. We also control other variables like the age, gender, race, ethnicity, etc. So 1,000 patients looked through the medical student with me at the time, did an awesome job, documented all the 1,000 patients. 532 of those who had a cholecystectomy did not have ultrasound within 10 days, or the ultrasound report did not show gallstones or sludge. So these were excluded. And then from the remaining 22 had no status of Murphy sign documented in the ultrasound report, so we excluded those. And 2, there was no also status mentioned whether there was no pericholecystic fluid. The total patients left were 444 patients. Out of those, almost half of them were negative ultrasound. And when I mean by word negative, none of the sign that I mentioned earlier was indicated. And we noted that was 32% of the negative ultrasound were found to be a missed acute cholecystitis when we looked at their pathology specimen. An interesting other finding was the other 230 patients that were positive ultrasound, the ultrasound predictability of acute cholecystitis was almost like a coin toss, like 58 and 42% of those who had. And this table kind of aligned the findings. The ultrasounds, you can see, it's almost, the positive ultrasound was almost half of them, and the negative ultrasound was 1/3 of the patient were missed. And also looked at the sensitivity of the test that was performed of the ultrasound to detect the acute cholecystitis on the pathology was 62%, and the specificity was 58%, and the total emission rate was 3%. We also looked at other variables to see whether these were found to be significantly predictive. And then the question was how much? The age was 2% for every year, will increase the likelihood. The white cell count was 11% for every 1,000 more. The the wall thickening was 200%, and the beta cholecystic fluid was actually 300% increase the likelihood of predicting the acute cholecystitis. And this was significantly, statistically significant. Other interesting finding that we found that ethnicity and gender were not a significant predictor for the pathology, and the sonographic Murphy sign was not also statistically significant. Limitation, it's retrospective data, and there's also a lack of documentation of history and physical in most of the charts that goes toward this. And there was also a lack of consistency of the synopsis report of the ultrasound to document all the signs. So in conclusion, negative ultrasound screening criteria according to the study that we conducted can miss up to 1/3 of the patients, and however also positive ultrasound can overdiagnose over half of the patient, and parameters such as age and white cell count should be considered. With that I end, and great thank you to SAGES, and thanks to the students who I could not convince them to go to surgery. As you can see down, everyone went to a different specialty. Thank you very much. Happy to take any questions.